I'm Dr. Prashanth B, medical gastroenterologist practicing at Bangalore. On behalf of Evolving Gastroenterologists Association and Retish Talk, it gives me immense pleasure to tell you all that the next speaker for the topic of evaluation of gastrointestinal motility is a legendary consultant that we all know. Every gastroenterologist in India are proud of him. He is none other than Dr. Professor Uday Ghoshal, sir. Sir has many accolades under his name. To name a few, I would want to just tell a few things. Sir is currently a senior consultant and professor gastroenterology and chief in Luminal Gastroenterology and GI Motility at Institute of Gastro Sciences and Liver Transplantation at Apollo Multispeciality Hospital, Kolkata. He was formerly a professor and head in Department of Medical Gastroenterology at SGPGI, Lucknow. Sir is the president of Indian Neurogastroenterology and Motility Association. Sir is president-elect of Indian Society of Gastroenterology. Sir has been part of various important committees that has recently launched various guidelines. He is member of Rome 4, Rome 5, and also the Chicago's classification of esophageal motility disorders. So it gives me great pleasure to listen to Sir on this particular topic. Thank you, sir, for giving us this privilege to listen to you. Thank you.
So, good evening, everyone. I will be talking on evaluation of gastrointestinal motility disorder. So, I will talk a little bit on concept of esophageal manometry, gastric emptying scintigraphy, wireless motility capsule or smart capsule. I'll also talk about a little bit on Atmo capsule, Electrogastrography, Antroduodenal manometry, colon transit using radio-opaque marker, and anorectal physiology testing. Obviously, since the topics are quite large or vast, we touch on concept of these. And maybe later we can talk in greater detail. We talk about mechanism of swallowing, and this can see in the left cartoon. This is the picture of esophagus. Now, in the bottom of it, you can see lower esophageal sphincter, and below that is the stomach. When somebody swallows food, the food enters into the esophagus, and this produces a pressure, and this pressure is called intrabolus pressure. And this intrabolus pressure you can see in this high resolution manometry signal as a sky color vertical line. Now, the moment this bolus is in the lumen, the esophageal muscle proximal to the bolus contracts. And this leads to a pressure which is called esophageal contractile front, esophageal contractile front. At this time, lower esophageal sphincter relaxes, and the residual pressure that remains even after lower esophageal sphincter has relaxed is called integrated relaxation pressure. If the esophageal contractile front pressure is sufficiently higher than the integrated relaxation pressure, the bolus goes forward and enters into the stomach. Now, in the Klaus plot that you can see on the right side, you can see here this is esophageal EUS opening. You can see a sky color vertical line. This is intrabolus pressure. And this is the esophageal contractile front, which I will discuss later. We measure it as distal contractile integral. So what is distal contractile integral? It is amplitude into duration. That means contraction amplitude into duration of contraction over an unit length. And this is distal contractile integral. And below is the LES, and you can see the LES pressure, the integrated relaxation pressure has been marked here. What is integrated relaxation pressure? It is the average minimum residual pressure over a 4-second window, which need not be continuous in the LES after the swallowing has been initiated. Okay? And typically, the IRP or integrated relaxation pressure is to be less than 10 millimeter of mercury. Now, when we talk about esophageal motility disorder, you have primary esophageal motility disorder and secondary esophageal motility disorder. The primary disorders include disorder of EGJ outflow and disorder of esophageal peristalsis. What are the disorder of EGJ outflow? These are type 1 achalasia, type 2 achalasia, and type 3 achalasia. In achalasia, the integrated relaxation pressure is high, but in addition, they have simultaneous contraction. What is the meaning of simultaneous contraction? Simultaneous contraction means that there is a very low distal latency. Typically, distal latency means that when the upper part of the esophagus is contracting, the lower part has to relax. And therefore, there is a slope-like contraction that moves us to the lower. This move slope is to a distal latency more than if distal is less than 4.5 seconds, this is simultaneous contraction. So in type 1, type 2, and type 3 achalasia, the contractions are simultaneous and IRP is high. EJG outflow obstruction refers to a condition where the LES is not relaxed, therefore IRP is high, but the distal latency is normal. Now, disorder of esophageal peristalsis include distal esophageal spasm, hypercontractile esophagus, absent contractility, and in esophageal ineffective motility. This is Chicago classification version 4, which actually depicts all these that I have said in a greater detail. And as you can see, on the left side yellow box are disorder of EJG outflow, and this include achalasia type 1, type 2, type 3, and EJG outflow obstruction. On the right side, we have depicted disorder of peristalsis, which include absent contractility, distal esophageal spasm, hypercontractile esophagus, and ineffective esophageal motility. And these are some of the cutoff. For example, if the distal contractile integral is less than 100 millimeter of mercury per centimeter per second, this is failed peristalsis. If it is between 100 millimeter of mercury to 450 millimeter of mercury per centimeter per second, this is weak peristalsis. Whereas if DCI is more than 8,000 per millimeter of mercury per centimeter second, this is hypercontractile esophagus. Now, what are the contraction pattern? For example, distal latency If it is less than 4.5 seconds, this is premature contraction. If there is a break in the esophagus or esophageal contraction, now normally small breaks such as of 2 centimeter is quite normal. But if there is a large break, for example, more than 5 centimeter, then this is abnormal. And when none of the above are there or is there, then this is intact or normal peristalsis. These are the few examples of high resolution manometry. The first one is a normal manometry. Below that, you can see there is hardly any contraction in the body of the esophagus and the LES pressure is low. This can be ineffective esophageal motility, or, for example, typically you find such a motility pattern in scleroderma, where the body of the esophagus doesn't contract and the LES is very low pressure. In achalasia cardia, particularly type 1, after LES directed therapies have been done, you can get a similar pattern. Now, this is this one is a large peristaltic break, and this one is hypercontractile esophagus. Now let us now come to the stomach physiology. We all know stomach empties both liquid and solid. And let me tell you, physiology of liquid emptying is quite different than that of the solid emptying. When we drink liquid, typically stomach muscle contract. And we all know the circular muscle, longitudinal muscle, and oblique muscles are the three layers of muscle in the stomach. The oblique muscle falls short by about 1 centimeter from the lesser curvature. Contraction of the oblique muscle divide the stomach longitudinally into two parts. One is on the greater curvature side and one is on the lesser curvature side. The lesser curvature side that produces a tunnel, which is called gastric canal. Also, this is called mesentery, through which the liquid is supposed to empty without any delay. But typically, liquid emptying is delayed by 15 to 30 minutes. And how does it occur? This occurs because of the receptive relaxation of fundus of the stomach mediated by vagus nerve. And hence, if somebody has vagal neuropathy, his liquid emptying is faster than a normal person. Now, on the other hand, if you look at the solid emptying, the moment we eat solid, actually solid goes quickly to the antrum. The moment solid reaches antrum, the pylorus constricts, the pylorus closes, leaving only 1 to 2 millimeter size lumen through the pyloric channel. Now, the antrum of the stomach contract, which lead to whirlpool movement within the lumen of the stomach, and this leads to churning of the food along with the enzymes that work there and hydrochloric acid. Now, obviously, the foods are churned into small particles, and the heavier particles move in the periphery, whereas smaller particles are in the center. And when the particle size become 1 to 2 millimeter, then it goes through the pyloric channel. And this takes almost 90 to 110 minutes to empty the solid. And in contrast to liquid emptying, well, vagal neuropathy leads to faster emptying. In case of solid, vagal neuropathy leads to lack of contraction of the antrum and therefore delayed gastric emptying. And this is the reason why in gastroparesis we have to test for solid gastric emptying and not liquid gastric emptying. Now, this is solid emptying is studied by 99 M technetium sulfur colloid. Liquid emptying we know is studied using 111 indium, but we are not too much interested in liquid emptying. We are more interested in solid emptying. Now, these are some of the pictures of gastric emptying scintigraphy. And if you can see the normal in 2 hours, if there is more than 60% retention of the solid during solid emptying scintigraphy, it is abnormal. And if at 4 hours more than 9% is retained, this is abnormal. Okay? So now let us look at wireless motility capsule and Atmo capsule. The wireless motility capsule is also known as smart pill. The smart pill studies the temperature, the pressure. Also, it studies the pH, and therefore it is able to tell us the emptying of the different parts of the GI tract. However, smart pill is now practically disapproved by FDA. Therefore, we are waiting for a better technology, and this is an Atmo capsule which had the so we had the opportunity to evaluate in our department at SGPGI Lucknow when I was there. And there, this Atmo capsule is currently under consideration for approval by FDA for studying, emptying, and maybe in due course of time, we'll see it. So gastric function and dyspepsia, as I told you, that if somebody has lack of receptive relaxation of the stomach, this is associated with PDS type or postprandial distress syndrome type functional dyspepsia. On the other hand, if somebody has emptying problem of the antrum, obviously this is more like gastroparesis. Electrogastrography is another technology. Currently, we are using in our lab 3-lead electrogastrography. And in addition to electrogastrography, we use water load satiety test, which is the standard now for assessing EGG. So today we don't do just resting EGG, but we do water load satiety test-based EGG, so that you are studying the gastric myoelectric pattern at rest, then you are giving the water volume to ingest, and also you record how much volume could the patient ingest. Typically in patient with gastroparesis or lack of fundic relaxation, they are able to ingest less, and then you see the GMA pattern. And this is from our lab where we found that the change in the GMA or dominant power change following ingestion of the liquid gives a lot of information about gastric physiology. Obviously, stomach is a big organ, stomach is a complex organ, and studying that organ using a 3-lead EGG is not enough. And therefore, this is a technology which has 64-lead electrogastrography. And we are very soon going to get it in our lab, I believe so. Antroduodenal manometry is another important technology to study the antral and duodenal contraction, and this is from our lab. Now here you can see the upper two ports are located in the stomach and the lower ports are all in the duodenum and jejunum, and the initial part is fasting AD manometry signal. Subsequently, patient has taken meal here, and this is the post-meal signal. And then at the end, we typically use to inject octreotide intravenously 50 milligram and see the octreotide induced MMC development. Now there are now high resolution Antroduodenal manometry system. There are now high resolution Antroduodenal manometry system, and the high resolution Antroduodenal manometry system is called manometry system. It also gives you spatio-temporal topographic plot. Now, how to evaluate constipation? Typically, for constipation evaluation, we use 4 tests. And what are these 4 tests? It includes difficography, balloon expulsion test, anorectal manometry, and colon transit study by radiopaque marker. What do you do in balloon expulsion test? We use an infant feeding tube, and in the top of it, we tie a condom, and then this is inserted into the rectum. The balloon is filled with 50 ml of water, and then subsequently patient is asked to evacuate the balloon while being in the left lateral position. There is another technology of balloon expulsion test where instead of being in the left lateral position, patient goes to the lavatory, uses a stop clock, and sees how much time did he take to evacuate the balloon in privacy in the lavatory. But in the conventional balloon expulsion test, the patient is lying in the left lateral position, and then if he or she cannot evacuate out the balloon, you add weight in the other side of the balloon, that is other side of the infant feeding tube. And if somebody requires more than 250-gram added weight to evacuate the balloon, this is considered as normal and is a very good screening test for fecal evacuation disorder. So if some of you do not have the ability, to do manometry now, because you may not have your machine in your lab, I would say use balloon expulsion test. And this can be a good screening test for your patient. Also, people have shown that if you train your finger to do a good quality rectal examination, not merely looking at growth in the anorectum and blood in the finger stop, but assessing the resting sphincter pressure, squeeze sphincter pressure, and then ability of the anorectum to evacuate out your finger. This has almost 60 to 70% ability to detect fecal evacuation disorder as compared to anorectal manometry. Now let us now come to colon transit study, which is a very important test. And if you look at the history of colon transit study, Evans first described colon transit study, in which he gave 20 radiopaque marker to the patient for ingestion. And then subsequently, he collected the stool and put the stool in the X-ray machine and radiograph the stool to see when all these 20 markers went out from the body. Subsequently, you can see Arhan developed a technology because radiographing stool is cumbersome, not very acceptable to the laboratory. And therefore, what Arhan did is, instead of X-raying or radiographing the stool, he X-rayed the patient every day. Now, 20 radiopaque marker is given in day one, and then radiograph your patient every day. But the criticism is you're giving too much radiation. for just assessing colon transit. This is a very landmark discovery by Metcalf. So what he did is instead of radiographing the patient every day, he did, he gave marker, 20 radiopaque marker every day for 3 consecutive days. And then he x-rayed the patient after 24 hours of ingestion of the last set of marker. So this is a good technology because you are not radiographing the patient every day. But only problem is from India, when I was in Calcutta between 1995 to 2000, we tried this technique in our patient. And in most severely constipated patient, all the markers were out. Even Dr. Sobna Bhatia from Mumbai did the same and published. And she found the same, that even if you take severely constipated patient, radiopaque markers become out if you follow this technology. So therefore, we modified this technology. And what we did is we gave radiopaque marker 20 at 0 hour, 20 at 12 hour, 20 at 24 hour, and then did abdominal radiography at 36 hour and 60 hour. At 36 hour, if there are more than 30 markers, it is abnormal. At 60 hour, if more than 14 markers are retained, this is abnormal. And in fact, we developed this marker indigenously and we patented this in as early as 2016. And today, I'm happy to tell you that we received the patent from Government of India for 20 years. And maybe in a month or two, the marker is going to be in the market after DCGI approval. So already currently it is in DCGI office and being evaluated. And these are some of the marker studies where you can see the X-ray at 36 hour and 60 hours. Now, what about anorectal manometry? Anorectal manometry, you put an anorectal manometry catheter. Catheter of different designs are available. Typically, many of these catheters have balloon at its tip for assessing rectal sensitivity, for assessing rectal inhibitory reflex. So first, what you do is after placing the catheter into the anorectum, you check the resting sphincter pressure and then ask the patient to squeeze, assess the squeeze sphincter pressure, and then you ask the patient to cough and see the normally this is nature's system so that fecal incontinence doesn't go to coffee. And then ml air and so on to study rectoanal inhibitory reflex. And then also you had simultaneously study the rectal sensation. And finally, you ask the patient to defecate. When the patient is trying to defecate, in normal circumstances, the rectal pressure will increase and anal pressure will decrease like this. But in abnormal circumstances, there could be dyssynergia. Type 1 dyssynergia, this is a system which Satish Rao has developed. Type 1 dyssynergia means the rectal pressure will rise, but simultaneously the anal pressure will also rise. Type 2 dyssynergia means the anal pressure will rise and the rectal pressure will not rise. Type 3 dyssynergia means rectal pressure rises by more than 40 millimeter of mercury at least, but anal pressure failed to fall by 20% from resting. And type 4 dyssynergia is the worst situation where the rectal pressure doesn't rise, but anal pressure also doesn't fall. So therefore, these are the 4 types of dyssynergia. And today we really don't know very well what is the clinical significance of different type of dyssynergia. Is it that type 1 dyssynergia or type 2 dyssynergia would respond better to biofeedback than type 4 dyssynergia. There is hardly much literature on this, and it is an important aspect to study. Quick ultrasound of anal sphincter, and this is very important. You know why? The reason is that manometry gives us sphincter function, but we also want to know the sphincter structure. And typically, we use an endoscopic ultrasound machine which is radial and not linear. So this is the case where radial endoscopic ultrasound is used. In most other places, it is linear, which is preferred. Now, you raise the megahertz to about 12 megahertz frequency range. And also, you magnify it and visualize the sphincter very well. And you can see here, this round black structure is the internal sphincter. The smooth muscle looks black. And the surrounding white structure is the external sphincter. And we can measure the thickness of internal sphincter, thickness of external sphincter. So see, like in this patient, that is the sphincter broken, like in this case, internal sphincter is quite broken, and even the external sphincter is broken. You can use also use elastography during fibrosis of anal sphincter, and all these have clinical importance. For example, if we find there is a total tear of anal sphincter, probably there is no point of trying biofeedback, but surgical repair will be preferred. Now, this slide is very, very important. This is one of our study. And over a long period of time, maybe 15 or 20 years, what we did is we found 60 patients. This is a retrospective analysis. We found 60 patients were diagnosed as either gastroparesis or pseudo-obstruction. Now, what we looked at, there were 40 which were primary disorders, primary gastroparesis or primary pseudo-obstruction or colonic inertia, and 20 were secondary disorder. That means somebody has uncontrolled diabetes, hypothyroidism associated with this disorder. We compared the two groups and we found that primary disorders were more often missed. Whereas secondary disorder, again, they were missed, and most of these patients were labeled as functional GI disorder, and the motility disorder was not even diagnosed. Second is primary disorder patient more often underwent surgery. Secondary disorder patient less, but again, there also surgery occurred. And then we did a survey to know awareness. This is called KAP survey, knowledge, attitude, and practice survey. We wanted to study the awareness among the physician and gastroenterologists about utility of motility test and availability of motility test and their attitude towards motility. And to our utter surprise, we found the awareness is very less. In fact, when you gave a question that a patient who present like gastroparesis, we asked, what is your diagnosis? Most physicians or gastroenterologists answered that this is functional dyspepsia. But when, after this question, we asked if the same patient is diabetic with repeated syncopal attack, what is your diagnosis? Gastroparesis featured in their diagnostic list. What does it mean? That primary disorders are not even thought about. Also, there are lack of facilities for motility testing in many places, and therefore it suggests to us maybe a lot of these motility disorders are remaining undiagnosed in the country. And there is a need for better diagnostic facilities, more educational session, and that is going to benefit the patient with this disorder. Thank you so much. I really acknowledge all the people who supported my work for more than 2 decades. I also thank the funding agencies such as Indian Council of Medical Research, DST, DBT, and so on. I thank SGPGI Lucknow, where I did most of my motility work, and I thank the current faculty members in the department where I work now, Gastro Sciences and Liver Transplantation at Multispeciality Hospital, Kolkata. In fact, we had an opportunity to establish one of the finest motility laboratory in the country just a month ago with all the motility facilities, whatever we have. Thank you so much. Any question, I love to answer.
Thank you, sir. It's been a great pleasure to have a stalwart like you who put the entire GI physiology of in India in the roadmap of the entire world. So it's been a great pleasure to have you represent our country in major podiums and also to have you here with us, which is very nice to have you here. We have a lot of junior practitioners and consultants in gastroenterology interested in GI motility sciences, and you have given an overview of the entire evaluation and where it stands. So, thank you, sir. It's a great pleasure to have you here. Sir, one of the question that in the chat box they've asked is from Bangalore by Dr. Manmohan. So, what's the role of London classification in dysenergic defecation?
Yeah, London classification. See, earlier, both in esophageal motility and anorectal motility, there was no standard classification system. So that led to heterogeneity, that led to complexity. It is good that now we have a standard Chicago classification of esophageal motility disorder and subsequently a London classification of anorectal motility disorder. Actually, both Chicago and London not only tells you how to classify each disorder, but also tells you how to do the motility study. And in fact, what we do in our lab is we take the protocol how to do manometry there and then put in the form of a framed picture and then interpretation system. So it is a standardized system to classify anorectal motility disorder. So you will say that this is dyssynergia or this is normal manometry and this is unspecified motility disorder, anorectal motility disorder, and so on. But typically speaking, London classification is a classification which is developed in the West, may be very, very applicable to them. But if you want to use an Indian protocol, we have published Indian consensus on chronic constipation, where you will find how to investigate anorectal motility disorder. So typically we use both London system as well as Indian system.
Thank you, sir. Second question by Dr. Karun. What is the significance of slow waves in rectal manometry?
Yeah, you see, sometime if in an anorectal manometry you start over interpreting, it is not great. See, try to understand how does if defecation occurs? Defecation occurs because of the contraction of the rectum. These are called rectal motor complexes. And when rectal motor complex is occurring for any smooth muscle, we know there are slow wave and then action potential. Slow waves are the waves which are spontaneous depolarization activity happening in the muscle continuously over the day. And pace setter potential are the potential when on the top of the slow wave, you get a depolarization of the level which crosses the threshold value for contraction. So if you have a slow wave of a particular number, so obviously the contraction is happening much lower than that, because every slow wave doesn't have a pace setter potential. Every slow wave doesn't go above the threshold for contraction. And this produces rectal motor complex, which is important for defecation. But let me tell you, more than rectal motor complex in anorectum as compared to esophagus is abdominal muscular activity. Abdominal parietal muscle are the skeletal muscle or voluntary muscle. It is perfectly under our control, and we contract this muscle voluntarily to increase the intrarectal pressure. So only small part of intrarectal pressure is produced by rectal muscle. Large part is produced by voluntary muscle contraction. And then we have to relax the anal sphincter. In anal sphincter, internal sphincter gets relaxed by rectoanal inhibitory reflex. Whereas external sphincter is a voluntary muscle, we ourselves relax it. And when there is a gradient between intrarectal pressure and the residual anal sphincter pressure, then only defecation occurs. I hope it answers to your question.
Thank you, sir. So the next question is by Dr. Zubin. Based on EGG or ADM, how do you decide your medications in gastric dysmotility? When prokinetics and which one? And when for TCS or SSRIs? And lastly,
See,
hmm,
yeah, please.
sorry, sir.
Please
And
go ahead.
lastly, what's your referral point for G poem or pyloroplasty?
Yeah, very good question. I tell you, first I see the patient, take a very good history. I follow all the Rome criteria while taking the history, or Rome questions while taking the history. Second thing is, many a time, if I find the patient is describing a history that is leading to a lack of receptive relaxation of conduct, we ask the patient to drink in front of me. Now, how much volume can he drink? And in busy clinic, if I to let him or her drink in front of me, the other option is doing an AGG, where the fellow will get a restrained GMA, followed by water load and the volume of water he could ingest, and then post-water load GMA or gastric myoelectric activity pattern. Now, if I find that this patient has nausea, vomiting, important symptom, also I assess nausea, vomiting by GCSI, that is a cardinal gastroparesis cardinal symptom index. And then if I find there's an abnormal GMA, the water load that patient could ingest is very low, and often we do a gastric emptying for solid. And all this, if it tells me that this is a patient of gastroparesis, my line of treatment is entirely different. There, I don't use all these neuromodulator because they delay gastric emptying. What I do is that I will give them prokinetic, I'll give them fundic relaxation, for example, aconitamide, which is also a and sometime I give them. Now, if the patient doesn't respond to this therapy, obviously I modify their diet. If the patient doesn't respond to the therapy, then I have option of either botulinum toxin into the pylorus or pyloric balloon dilation or G-point. On the other, if I find this patient doesn't have nausea and vomiting much, I find the patient can take good volume of water or reasonable volume of water. GMA is not too bad. Gastric emptying is. I know I'm dealing with a patient of functional dyspepsia. Their initial PPI prokinetic, no response. I go to neuromodulator.
Thank you, sir. Next question, diabetic gastroparesis, what is from medications do you approach, sir? This is a question from back.
Yes, yes.
For diabetic gastroparesis, what are the medications approach that we try, sir?
I always give them prokinetic. I see that they are not having concomitant drug which can delay gastric emptying. For example, anticholinergic or maybe some of the neuromodulator, even antacid can delay gastric emptying, sucralfate can delay gastric emptying, anticholinergic can delay gastric emptying. Also, I want their blood sugar to be well controlled. Among prokinetic, I have a particular preference to etopride because etopride works by dopaminergic as well as serotonergic as well as some degree of cholinergic action. So multiple mode of action, less side effect, and good evidence in the literature. If somebody has both upper GI symptom as well as lower GI symptom, I prefer procalopride over etopride. Now, if the patient doesn't, I always modify their diet to give less fiber, chew well, small volume fluid, semi-solids are better tolerated than solids. Now, if they don't respond to it, then I give Botox injection. I know there could be two other competitive options. One is balloon dilation and G-point. But since diabetes, some of the gastroparesis may be reversible, I do not prefer G-point in them very early. Antroduodenal is a very irreversible condition which occur in prolonged diabetes, uncontrolled diabetes.
Thank you, sir. So next question from Delhi. They have asked about IRP4 versus IRP2 or IRP7. Means why 4-second window was taken to measure IRP by Chicago? Why this 4 seconds?
Very good question. My answer, I don't know what Chicago did, but I have explanation of my own. I don't know whether Pandolfino thought the same or not. If you look at the esophageal transit time, the average transit from the upper esophagus to ileus is 8 seconds. 8 seconds. Obviously, if you divide this 8 seconds into two halves, one for the upper part of the esophagus, where food is trickling down the upper part of the esophagus, then it is not required the ileus to relax. But if you look at the lower part transit, it will be around 4 seconds. Divide the 8 seconds into two halves. So you want during this 4 seconds, when food is lying in the lower, ileus should intermittently open at least for 4 seconds. Then only all this food will trickle down to the stomach. So possibly, I don't know whether Pandolfino thought the same or Chicago committee thought the same, because I was not a part of Chicago 3. I later became a part of Chicago 4, and this 4 second was introduced in Chicago 3. But this is my possible explanation.
Okay. Thank you, sir. Next, by Dr. Aditya, does EGG have a routine clinical use or is it more of an institutional modality?
What I understand is, if I understand my patient better, I can treat them better. I can prognosticate them better. Every upper GI disorder become functional dyspepsia by one or two questions, not even using rope questions, then I think you cannot solve the problem of the patient. Because if you are a lumper, then the life is good for you because you don't have to dissect within the diseases. But if you are splitter, then it is a difficult life for you because you have to have more technology, you have to have more knowledge, and you have to spend more time with the patient. Will benefit patient. So therefore, I know that Rome may not agree entirely with me, but I am a splitter. I want to treat this disease as best. Gives me better understanding about the patient problem, better ways to treat them, and maybe better out. So therefore, I believe EGG is required. Current EGG is a 3-lead EGG. 3-lead EGG is not great in itself, and that's why I'm going to get 64 EGG soon.
Great, sir. So waiting for the alimentary. Second, you said that the capsule, wireless capsule has been FDA has disapproved it, and Atmo capsule is being evaluated. What was the reason that FDA disapproved an Atmo capsule? What is the advantage over the existing previous capsule, sir?
I don't really know why FDA disapproved it after a long time. Sometimes all these disapproval are not related to FDA alone. Maybe the company did not want to continue. Maybe company was not doing economically well. And we all know the smart pill was very expensive, almost 300 to $350. Now you will ask me, what is the advantage of Atmo over smart pill? Advantage of Atmo over smart pill is ability to study GI gas. For example, hydrogen. It gives temperature, but it gives temperature. It gives temperature. It gives hydrogen. It gives pH. So therefore, because of hydrogen, it will be a good technology. It will be a good technology, I believe, to diagnose bacterial overgrowth or maybe gut microbiota metabolite assessment. And in fact, I was suggesting to them, why don't you try also to study methane using Atmo capsule and hydrogen sulfide by Atmo capsule. They informed me that hydrogen sulfide is very difficult to measure, but methane they would try, but again, it is much more difficult than hydrogen. So this will be an advantage because you will see a whole of the environment of the gut, what is happening after eating and all these, and this will be useful. This is what I believe. But obviously, I have a conflict of interest because I was part of the study and we received research grant from them.
Nice to know. Sir, when you had mentioned about colon transit studies, there was a difference between what was there and we had to change the 20 radio the markers. Why do you think that Indians, it was getting, though the patient is severely constipated, it was all coming out, sir? Like,
Because gut transit time in India is very short. You know why? Because in the West, if you look at the normal gut transit time, it is more than 30 hours. And look at Indian gut transit time, it is about 16 hours. And it is quite understandable because in the West, if somebody passes 3 stool a week, he is normal. Whereas in India, if the patient even passes 1 stool a day, he said, "Doctor, why not 2? Why 1?" So, therefore, this fast gut transit time might be related to one, vegetarianism, large volume of food that we have to eat because of the less calorie dense food. Second is that because we have lactose intolerance, that also have a laxative effect, and the milk intake have a laxative effect. And third, intrinsically, our motility is faster than that in the West.
oh, thank you, sir. Sir, antroduodenal manometry, how common is it being done, and what do you predict the future? Would it be taking over a significant number of centers will be taking over antroduodenal manometry, or still a lot of research is left in the machines?
Antroduodenal manometry is a very standardized technology. It was there in practice for many years, more than 5 or 6 decades. So what I am saying is, only thing is that these are very sophisticated technologies. We did in SGPGI a lot of antroduodenal manometry, maybe in hundreds. And we understood disease phenotype or pathophysiology in many patients. We have published so quite extensively. It is a very good technology. But only thing is, we use antroduodenal manometry machine that was developed by Dr. S.N. Reddy. Name is Reddeck. The machine is not available anymore. Now, obviously, not wide availability of having a machine, not having many dedicated motility lab who want to advance things further. This is the possibly the reason why antroduodenal manometry is not so popular. But since we have done in a lot of patients, it gives good insight. Also, you have to have enough time to do all this. Because if you are too busy seeing large volume of patients, large volume of endoscopies, possibly these areas cannot develop. But like in any country, what happens is as your some areas get saturated, then young generation becomes more dedicated to take areas which are less saturated. Now, therefore, possibly with time, things may be in the right direction. We also need that we should develop India-made motility machine or manometry machine because then it will be cheaper, maybe make in India will be good, better. Like we look at the car, like look at COVID vaccine, look at all these war machineries. So probably this has to come in medical science as well.
Yes, sir. A great lesson taken for future by all of us too. Sir, the allotted 1 hour time is done. Thank you for the great talk, which was done in time and for answering all our questions. Looking forward for more such nuanced classes, sir. Thank you.
Thank you.